The seamless introduction of purely laparoscopic donor hepatectomy in Cleveland Clinic. The case number of minimally invasive donor hepatectomy is increasing, and more than 2,000 cases were done until 2019. Half of the cases were done by pure laparoscopic approach, and those were mainly reported from Asian countries. The case number of minimally invasive donor hepatectomy in the United States is smaller comparing to the Asian countries because of a smaller number of living donor liver transplant itself and also slow spread of minimally invasive approach in liver surgery. Until 2019, 245 cases were done in the United States. However, those were mainly used hybrid approach, and number of pure laparoscopic or robotic approach was still small. Until today, only one US center reported large number case series. In Cleveland Clinic, we started minimally invasive liver surgery since 2006. The case volume increased gradually in first few years. However, we had a stagnation period. The case volume did not increase for 5 years between 2012 and 2016. However, because of many changes we made in 2016 and 2017, our case volume started to increase after that, and now we have nearly 100 cases volume per year. This is brief timeline until we started laparoscopic donor hepatectomy. As I mentioned, we had a good case volume increasing in middle of 2017. Then we started discussing about introducing lap donor hepatectomy. At that time, our plan was to start from left lateral section graft for pediatric patient. However, fortunately, we found Dr. Kwon, and at the time he was looking for the institute he can start laparoscopic donor hepatectomy. So we started recruiting him. Meanwhile, we had a first pure laparoscopic donor formal right hepatectomy in March 2018. Then Dr. Kwon joined end of 2018. After he joined, we spent more than 6 months for preparation. Even he had experience of donor hepatectomy in South Korea. For safe and smooth introduction of donor hepatectomy, we spent long time since end of 2017. There are 3 key factors which we thought important to smoothly introduce lap donor surgery. Before mentioning those 3 factors, I would like to emphasize that most important thing is financial support from institutes. And if you don't have it, I think nothing will happen. Of 3 important factors, human resources most important. We believe at least 2 skilled laparoscopic liver surgeons are needed for starting lap donor hepatectomy safely and make it routine surgery. Skilled means that the surgeons who has both expertise in laparoscopic surgery and liver surgery. Donor surgery have to be 100% safety, so therefore we think proctorship is mandatory. However, it is very difficult to find or hire somebody who has both lab donor experience and US medical license. For future expansion of lab donor hepatectomy in the United States, we have to come up with solution how to get proctorship smoothly. One more important part is dedicated nursing or scrub tech team. We made a dedicated lab liver team, and they always scrub with us for more than 6 months before we start lap donor hepatectomy. Now they know everything, and they are give us the instrument smoothly, and they give us a setup, proper setup every time. Then instruments are also important. We can do complex lap liver surgery without those fancy devices. However, for safety and less stress for surgeon, institute or program have to invest a lot to develop program. After we decided to start lap donor hepatectomy, Cleveland Clinic allowed us to buy 2 3D towers, ASCO, and renewed all lab instruments, buy new basket clamp sets or needle holders, and 3D imaging reconstruction software. The last important key is developing culture of the program. In the overall, we did standardization of the procedures. Our setup devices were always the same. Port arrangement is basically the same for major hepatectomy. Also, we always did the same way for cutting liver parenchyma and mobilization. Everything is the same, always the same, and the same, using same device and the same approach. Outside oral, we also had a routine thing. We record all our surgery and archive for fellows and resident training. At the beginning, those routine thing was pretty difficult, but we kept doing the same thing for 6 months. Now everybody understand what we have to do, and we can do everything smoothly, and we could develop and make a culture, our own culture. After those long-term preparation, finally we started lap donor hepatectomy since August 2019. Until today, we already have done 50 cases, and 100% of donor hepatectomy was done by laparoscopically in 2020 and 2021. Nearly 100% of cases were adult to adults, and there was no conversion case, and none of the case required intraplatelet blood transfusion. This is an operative time distribution. Until case 30, Dr. Kwon performed all procedure and other surgeon helped him. After case number 30, I and Dr. Seho started part of the procedure, and because of that, our operative time is slightly increasing. Until today, we had 4 complications in pure laparoscopic cases, which was significantly lower to the rates comparing to the open donor hepatectomy. We had a 2 PV stenosis, and 1 case was fixed by stent bracing, and 1 case was fixed by laparoscopic portal vein plasty.